Hi, good afternoon and good morning. Welcome. I see it's noon Eastern on my clock, so in interest of time, I think we're going to start right away. So welcome everybody to our webinar series, Bridging HIV, HCV, and Substance Use Disorder Innovations in the Field. This is a webinar series that's hosted by the National Alliance for HIV Education and Workforce Development, also known as Nahoot, and in partnership with the AIDS Education and Training Centers and the Opioid Response Network. I'm Daria Bacher-Lattimore. I'm the president of Nahoot and the co-principal investigator on this project. And we also have joining us the treasurer of Nahoot, who's also the co-PI of this project, Vanessa Carson-Sasso. Okay, we will be recording this webinar and it'll be available on our website for folks as well. Okay, so just to quickly give you a little bit about who Nahoot is, it's a member organization of the 8 regional and 2 national AETCs. We support the AETC program mission. We were established in 2010, and we support the AETC program, which is a component of the HRSA-funded Ryan White HIV/AIDS program. And they have an explicit directive to build and maintain a well-educated and culturally sensitive health profession workforce that can provide prevention, diagnosis, care, and treatment and medical management for people at risk for and living with HIV. So Nahoot collaborates with multiple organizations in order to promote and educate on the work of the AETC program. And since 2018, we have been funded by the American Academy of Addiction Psychiatry as a partner organization of the Opioid Response Network to address the intersection of HIV and opioid use disorder. ORM was created to support efforts in addressing the prevention, treatment, and recovery of opioid use disorder, and provides free resources and technical assistance locally in communities across the United States and its territories. So please visit the ORM website for more information. You can also submit a request for technical assistance there. So we will be offering continuing education for today's webinar. So if you're interested in obtaining that, please remember to complete the evaluation, which you will be emailed within 2 weeks. And make sure that you are using the same email and name in the chat in your participant list as your registration email. And we will also put that link in this presentation at the end of the session. So your certificates are going to be emailed to you within 2 weeks of completing that evaluation. And of course, it's your responsibility to verify the requirements in your state licensing board. So with no further ado, I am going to introduce our speaker, and we're very pleased to have with us today. Let me stop sharing here. Here we go. Dr. Nyako is an assistant professor in the Division of Infectious Diseases at Rutgers, New Jersey Medical School, and a physician scientist. She's a graduate of the Northwestern University Feinberg School of Medicine, where she completed medical school, internal medicine residency, and infectious disease fellowship. She provides clinical care for people living with HIV and other infectious diseases, and her research interests lie at the intersection of HIV and substance use disorder. She is also the co-director of the Northern New Jersey Medication Assisted Treatment Center of Excellence, that is tasked with assisting the state in expanding access to medication-assisted treatment for opioid use disorder through education, novel service delivery, and community collaboration. So I am going to turn it over to you, Dr. Nyako.
All right, thank you, everybody. Let me go ahead and share my screen. All right. For today, as a part of the series of webinars, I'm going to be focused on the initiation of medications for opioid use disorder in the outpatient practice, and really with a particular focus on what that looks like in a setting that provides care for people living with HIV. But there are many principles that can be applied across many different treatment settings for people that may be at risk for HIV or thinking about hepatitis C treatment or prevention. So for our learning objectives, it's to understand what the initial assessment of someone who's coming to receive treatment for opioid use disorder, be able to perform MOUD initiation, and then also understand what aftercare looks like for that patient, and think about what we need to do in terms of our practices to make that more possible. In order to achieve those learning objectives, I'm first going to make sure that everybody's on the same page about the current status of the opioid epidemic in the United States. I want to make sure that everyone understands the effectiveness of medications for opioid use disorder, both as it applies to the general population, and more specifically when we're thinking about it in terms of the intersections of people with infectious diseases, particularly HIV. And then lastly, we'll talk in some concrete practical steps of what this will look like in your clinical practice. So first, let's talk about what is the current status of the opioid epidemic. So many times, since many of you are very interested, and it looks like already have some background knowledge about this topic, I'm not going to take you through talking about the various phases of the opioid epidemic, in which first in 1999, we really saw a big uptick in opioid overdoses related to prescription opioids. And then we saw a transition in 2010 to an increase in overdoses related to heroin. And then in 2013, we saw overdoses that were really being driven by fentanyl. What I want us to really focus on is what does even in this most recent year, what does the opioid epidemic look like? So for those of you that may not have seen the MMWR alert that came out about the precipitous rise in in overdose deaths in the United States, we hit the 100,000 patient or individual mark as of January 2021. And so prior to that, we were in the range of about 70,000 overdose deaths. Of all of these overdose deaths, about 3/4, 75% are due to opioids. And as we can see, there are many different things that the COVID-19 pandemic have done, and definitely increasing the vulnerability of people with substance use disorders to adverse outcomes directly related to COVID or downstream effects continues to exacerbate a public health crisis that we already knew was ongoing prior to the global pandemic. And just so that you can, I know that we've got an audience that's joining in from all over the country, and so that you can see that this is a problem across the United States. There are only a few states that actually saw a decrease, but overall there was about a 22% increase in the number of overdose deaths that have happened between May 2020 to May 2021. And so you can find your state, and the darker the shade of this kind of brownish color indicates a greater rise in the number of drug overdose related deaths. So I'm giving you what is the current status. This is really kind of hot off the press information, but we had already seen trends that are related to the opioid epidemic. And so now I'm going to tune you in and kind of give you information about what that means for infectious diseases. So this was with our opioid epidemic, we see that we have an increase in injection drug use. And with this increase in injection drug use, particularly of opioids, we've seen a dramatic increase in the cases of acute hepatitis C infection. And so this is just a snapshot of 10 years between 2004 to 2014. And the solid lines represent opioid injection, and then the dotted lines represent cases of of acute hepatitis C infection. And so we see that there's a direct parallel in terms of the cases of acute hepatitis C infection. And really the individuals that are particularly vulnerable to that are individuals less than 40 years old. And the most vulnerable of those are individuals between the ages of 18 to 29 years of age. Not only is this an issue in terms of thinking about our national strategy for viral hepatitis elimination, but this also, this also has a direct impact on our ending the HIV epidemic goals. So we continue, so prior to, we'll say 2010, the decreases in HIV infection in persons who inject drugs was one of the bright spots of our HIV strategy. You know, we have a tremendous success in the prevention of mother to child transmission of HIV. And then second to that would be the decrease in the number of new HIV infections in individuals who inject drugs. However, that has plateaued, and we see that there are outbreaks that have continued to occur across the country, primarily because of the rise in the opioid epidemic and it being widespread, but also because harm reduction services, as well as access to addiction treatment, has been very lacking despite this need. And so, you know, this has been something that has been of concern for some time. And I think one of the most prominent cases of this was in Scott County, Indiana, in which we went from a community that would have 5 new HIV diagnoses over the course of several years to having 250 new HIV diagnoses over the course of a year. And as we see in that parentheses, now they're at 235 by the end of 2020. And so the prevalence of HIV in this one community is about 3% as a result of this outbreak in persons who inject drugs. But it's not just in Indiana. We can see in Washington and Oregon, West Virginia, there's been concern in Massachusetts, Philadelphia, in Pennsylvania, as well as in my own state of New Jersey, that we've seen outbreaks. And so this continues to be of concern and really represents the need for a comprehensive approach that includes not only prevention services and drug treatment services, but also rapidly identifying individuals that have HIV, looking at cluster outbreaks, in employing a public health response, as well as getting those individuals rapidly into treatment so that they can achieve undetectable viral loads. Precursors to the development of to the acquisition of viral hepatitis or HIV are actually in an increase in the incidence of serious bacterial infections. And so from this study that was conducted, this was basically using one of the largest data sets around hospitalizations that occurred across the United States. We saw that there was roughly 36.5 million hospitalizations that happened in 2020. That was not that different in 2012. They looked at how many of those hospitalizations were related to opioid use. So that had gone up by about 50% over 10 years. And then we saw how many of those not only were related to opioid use, but also opioid use with a serious infection such as endocarditis, osteomyelitis, septic arthritis, or epidural abscess. And what you can see here is that we have at least doubling, if not tripling, of the rates of serious infectious diseases. And these serious infectious diseases represent not only an increase, the potential increase in mortality that can be associated for someone that has an opioid use disorder, but also an increase, significant burden or outsized burden, I should say, of healthcare costs costs that are associated with it. So it's imperative, not only for the health and safety of the individual with opioid use disorder for us to think about what comprehensive treatment looks like, but it's also important in terms of thinking about our overall healthcare infrastructure and capacity to provide high quality care. So the question now is, what is the current status of opioid use disorder treatment? I've made it clear that, we see that there are a lot of there's a morbidity and mortality, increased morbidity and mortality that's associated with having an opioid use disorder. And so what is the current status? How well are we addressing this since we know that this is an issue? So this was taken from a researcher at Columbia that borrowed the framework that we use for HIV in terms of thinking about our treatment cascade, and tried, and using numbers, estimates that we had from 2013 around opioid use disorder, try to use that framework of identification, of estimating what would be the total population of individuals, looking at how many had received that diagnosis, were linked and engaged to care, and then received medications for opioid use disorder, and then picked retention on pharmacotherapy for greater than 6 months as a treatment outcome. And so what we see here is that about 2.5 million individuals met criteria for severe opioid use disorder. And then we start to see successive and precipitous drop-offs in both diagnosis, engagement, initiation, and retention, such that at best, we've got 10% of those that are in need of treatment, receiving treatment, and remaining on treatment. And so this next slide basically not only reiterates the fact that we have inadequate numbers of individuals receiving treatment, but also highlights the fact that we have a paucity of providers that can provide this treatment. And so here, at this time, when this came out in 2017, when they were looking at the provider shortage, especially particularly in the Midwest and the Mid-Atlantic, we saw that there was a really mismatch in terms of the capacity for providers to provide buprenorphine as compared to the rates of opioid overdose deaths that were happening in those states. And this disparity, continues to be highlighted and updated, and has not improved to match the rate that we're seeing in the increase in overdose deaths. So there are multiple options for how we can treat someone with opioid use disorder. We have methadone, buprenorphine, and extended release naltrexone. Here, not necessarily to get too much into the pharmacology of it, we have methadone that's a full a full mu receptor agonist, versus buprenorphine, which is a partial mu receptor agonist, and then extended release naltrexone that is a full mu antagonist. Methadone is oral, buprenorphine is oral, which can be either film or tablet. There's also an implant, as well as subcutaneous abdominal injections that can be either weekly or monthly. And then extended release naltrexone is a monthly injection. Excuse me. All right. In terms of the settings for treatments, for methadone, here in the United States is restricted to special programs that are licensed, or our opioid treatment programs. For buprenorphine, we can do treatment in any outpatient setting as well as inpatient settings. And then, except there's a requirement for registration with the DEA, which I'll talk about how to go about that towards the end of the presentation. So if you want to treat 30 patients or less, you don't need training, but you still need to register. If you want to treat more than 30 patients at any one time, you will need to do a training. So if you're a physician, it's going to be 8 hours, or if you're an advanced practice nurse or physician assistant, it's going to be 24 hours of training. And then for extended release naltrexone, there's no special licensing that's required for this. Now, it is important that, you know, if there's only one thing that everyone takes away from this, is that medications for opioid use disorder are the gold standard of care. Study after study has shown the decrease in mortality that's associated with it. But one of the very first studies, which is this panel here on the right, looked at receiving buprenorphine versus not, and retention in care. And so it was 20 patients in each of the arms. And here you see this significant drop off, that at 60 days, there was only one person that remained in treatment who was not receiving buprenorphine, versus you see for those that you see the retention and care on buprenorphine through the 12 months of the study. And in addition to the individuals that dropped out of care that were in the control arm, 20% of them died. And so this was one of the, you know, first studies, very integral to our appreciation of the significant need for pharmacotherapy as a part of, as the, you know, really the foundation of treatment of opioid use disorder. And so this, I think, is also important to highlight, that a lot of the detox programs are either inpatient or ambulatory withdrawal management programs. It's not sufficient for the patient to go into one of these programs without receiving pharmacotherapy, either during their time in the program or after discharge. Because the retention and care is really quite poor, and there is overdose risk, a tremendous overdose risk with that person returning to drug use. And so, which takes us to the panel on the left, which ended up being a meta-analysis. And this meta-analysis wanted to evaluate not only changes in mortality associated with being on MOUD, but also after discontinuation, and then as compared to no treatments. And so as we see, the lowest mortality rates are with the person being on MOUD, which is in the yellow. You do have an increase in mortality that occurs after discontinuation at 12 months, but the highest mortality, both all cause and then overdose specific mortality, is associated with not receiving any treatment at all. And so this becomes important because it can be discouraging when our patients either are lost to follow-up in care with us, or want to discontinue pharmacotherapy, but at the same time, we should not erect any barriers to our patients receiving any sort of MOUD, because that does have a benefit. Basically, receipt of that at any point in time does have a benefit on their mortality. And so we should keep that in mind as we think about our harm reduction principles, which I'll talk about a little bit more as we go forward. More specifically, there's been a nice, robust literature that's looked at the impact of MOUD on HIV outcomes. And we see a 69% increase in utilization of ART, as well as a twofold increase in consistency in taking ART. And then with that is a 45% increase in viral suppression. So any of these medications for opioid use disorder, be it methadone, buprenorphine, or naltrexone, has a significant benefit on HIV outcomes. And this really brings us to the crux of why this specialized topic is in a discussion is needed. Additional benefits, and that these apply to the general population, is the improvements that we'll see in physical and mental health, quality of life, employment, and management of other comorbidities as a part of being engaged in care, getting preventative services, and follow up with other kind of specialty cares. We've seen this demonstrated in the heart failure literature, for instance. We also see that in addition to MOUD reducing the mortality that's associated with overdose, but it also we see reductions, if not cessation, of opioid use. And then we see a reduction in criminal behavior and incarceration. Some of that, can be a little bit nebulous about how it's quantified, but nonetheless, that's there, and definitely decreases in utilization of emergency medical services, as well as, and importantly, a reduction in hepatitis C acquisition, as well as reinfection rates for those that end up getting treated with our direct acting antivirals. So now that hopefully everybody has been convinced about not only the magnitude of this problem, but as well as the strength of the evidence to support the utilization of medications for opioid use disorder as a part of the work that we do for caring for those living with HIV, and as well as thinking about that in terms of HIV prevention, I do want to shift us into kind of thinking about the practical and what does this look like as we try and adapt our practices. And so I think that I'll break this up into kind of 4 subdomains. First, we'll talk about that our language matters, and really getting all of our staff from the front end to the back end, if you will, to transform the way that they speak about people with substance use disorders, and all of the different attendant components is an important part of making our practice welcoming as we engage individuals with substance use disorders and care. And then we'll talk about what harm reduction looks like. Many of us, as a part of the work we do for caring with people living with HIV or at risk for HIV, already employ harm reduction as we think about sexual behaviors. And so this should not be something that's going to be too far from our norm. And then, utilizing a trauma-informed practice. Again, that's something that we all have very much an awareness of and are already utilizing. And then this continues to be important as we think about really engaging individuals with opioid use disorder. And then, as always, and like I've already said, the fact that medications for opioid use disorder are the gold standard. Again, making sure that not only now that, if you were not convinced before, hopefully you're convinced now, but then also making sure that that message is spread, again, from, the front end to the back end of your clinical practices, so that everyone is understanding and appreciates, this paradigm shift. So let's talk about words mattering. This, again, there's been a lot of highlight around this in terms of the need for person-first language as we think about the way that we talk about people living with HIV. And similarly, that applies as we think about how we try and engage someone with an opioid use disorder or other substance use disorders. So really, these, terms such as addict, opioid user, substance abuser is not something that in our clinical practices we should be utilizing as we speak about our patients, because again, they're humans and they may have certain conditions, but they are not the conditions that they have. I think what becomes very important is as we start to think about, various lab results, and particularly when we're utilizing things like urine drug screens, that it's really an objective assessment of what that lab results actually has. So, opioids were detected, oxycodone was detected, fentanyl was detected, there's no buprenorphine was detected, versus that your urine was dirty or your urine was clean. Because again, that can give the false impression or assessment that this is a judgment on that individual and their behaviors, rather than, again, we're just saying this is really kind of this binary situation that we're talking about. Similarly, as we think about talking to patients as they this process can be very cyclical in terms of returning to substance use versus stopping, is a shift to really describe that as a return to use rather than relapse. And then lastly, and I think importantly, is the move to really talk about medications as medications for opioid use disorder or pharmacotherapy, rather than referring to it as medication-assisted treatment or opioid substitution therapy. Opioid substitution therapy brings us into a bunch of different problems in terms of substituting one drug for another, and medication-assisted treatment has the problem of changing the framework of the importance that medications are not the foundation, but are instead an adjunct to other treatments. And so psychosocial treatments are very important, but again, the impact of medications is really the foundation. So what is harm reduction? So this is taken from the Harm Reduction International Health, Rights and Drugs UNAIDS report in 2019. There are a multitude of definitions that exist. There's not one codified, but at the end of the day, it's the idea that we should operate both thinking about our system level policies, programs, as well as individual practices that are aimed to minimize the negative health, social, and legal impacts of drug use, as well as evaluating our drug policies and drug laws. And so this is really thinking about justice and human rights, and how we can work with our patients or with our clients to enact positive change, and that is without judgment, coercion, discrimination, and doesn't require that individuals have to stop using drugs as a precondition for us to provide care for them, or it's ultimately treat the person in front of you as a person. And so similarly, we're not turning our patients away that have diabetes, that have elevated blood glucose, or our patients with high blood pressure that come in with elevated systolic blood pressure readings, and that similarly, we shouldn't be turning away our patients with substance use disorders that may continue to use, because there's still so many things that are important that we should be doing as we think about comprehensive care. So just as a reminder, why we should be adapting and shifting our focus is because of what is our understanding of what opioid use disorder is. And this is taken from the American Society of Addiction Medicine that NIDA has put out. They've adapted and they put this out. And so this is the high level understanding, is that opioid use disorder is a chronic relapsing disease that involves the brain, reward, motivation, and related circuitry. And so that this change results in compulsive drug seeking and use despite the harmful consequences. And so the majority of the patients that you see that are seeking treatment are aware that this is a problem, but the issue is that they cannot stop, and they want to stop, but because of these changes that have happened, it makes it incredibly difficult, and for some can be impossible without MOUD. And so this reiterates again that abstinence-based programs have low success rates. I've shown you some data on that. And then again, reiterates that long-term pharmacotherapy is considered our gold standard because of longer treatment retention and improvement in treatment outcomes. So now thinking about what this means for your clinical practice, I really think that we need to simplify, our approach. This doesn't have to be complicated. We don't have to, feel like this is so foreign and really only lives in kind of the domain of addiction specialists or psychiatrists. There are a lot of very good tools, screening tools that are out there that can be employed. I like this particular single item screen because it's easy to remember, and it allows a way to open up a conversation about individual substance use. And so from this, and this was was developed specifically for primary care settings. And so for this screening, it's how many times in the past year have you used an illegal drug or prescription medication for non-medical reasons. And so if the person indicates more than 0 days, then that should prompt you for a larger conversation of what that looks like for the person. So you'll be asking them about what that substance may be, what is the route, what is the frequency of their use. Now, for you to get to the place of, feeling confident that this person has a substance use disorder, the key here is really that it's compulsive drug seeking and use despite the harmful consequences. So the DSM-5 has these domains about impaired control, social impairment, risky use, as well as the pharmacologic criteria of withdrawal and dependence. And then they rate it from mild to severe. I think that as you listen to the narrative that your patients give you about, the social troubles that they have with either their relationships, issues showing up at work, money that is being lost, their escalating drug use that is impairing their sense of well-being, being hospitalized with overdoses, having skin and soft tissues infections as a result of their injection drug use, or other serious infections like I talked about with endocarditis, septic arthritis. Our patients having those outcomes are the indicators that they have a substance use disorder. And so that, I think, using that as a framework is really the key to assessing that there is a problem that your patient or client is coming in with. So this takes us to how do you do the assessment? So this is not that foreign, I think, for many of us that care for people living with HIV. There are many of the domains that we cover when we're first meeting the patient overlap with what you would do when you're specifically focused on assessing somebody substance use disorder for treatment. Similarly, we're going to want to know about the person's psychiatric history. We want to know not only are they coming particularly for us for opioids, but they may have other substances, which may be stimulants, marijuana, alcohol, tobacco. We talk a lot about trauma, both as we think about the general care for somebody living with HIV, and that similarly applies when we think about it more under the lens of substance use care. And then also their social determinants of health. So housing, transportation, employment, that also is important for us to make an assessment of, because it's going to be important for us to think about, comprehensive multidisciplinary care. On your physical exam, it really isn't that different from what we already do. For me, when I'm seeing my patients, especially those that tell me about that they also inject drugs, I'm going to also check the sites where they inject to see if there are any areas where there are skin infections, so that we can try and address that in the outpatient setting instead of it having to escalate to go into, urgent care or emergency department. And then checking for any stigmata of chronic illnesses. So does this person also have evidence of liver disease, because you're seeing, jaundice, ascites, those types of heart failure, those types of things. Labs, these will be your basic labs, again, with the idea that that's supposed to be cluing you in if there may be also some other chronic illness that's present. So checking your CBC, looking at your LFTs, renal function, assessing them for viral co-infection, STIs, doing pregnancy testing. In truth, the guidance that the American Society of Addiction Medicine puts out is that none of this, how complete or incomplete this is, should not preclude you from providing medications for opioid use disorder. So if you've made that assessment that that person does have an opioid use disorder, they, especially in this time of telehealth, if you're not able to do the physical, or if you're not able to do the labs, don't let that stop you if if the history that you receive from the patient is compatible. Next, it's about selecting the appropriate form of MOUD. So, and this can seem a little bit overwhelming, and I think that it is really it should be shared decision-making with your patients. Many patients have an awareness of some of these medications, if not all. And so, it's discussions with them about, perceptions about methadone, buprenorphine, or brand name Suboxone, or one of the major brand names is Suboxone, or the extended release naltrexone. So if the person says, that they don't want any opioid, then they're going to want extended release naltrexone. If they're interested, if they don't necessarily have a preference, then you may want to have an assessment about whether or not that person needs a daily, highly structured program. If they do need a daily, highly structured program, then referring them to an opioid treatment program for methadone, though some opioid treatment programs also do buprenorphine, that may be an option for the patient. But if the person say, they don't want to go every day to a program, then that's where we get for buprenorphine. And so you can, that's, I think, the basic gist of this slide. I know that the slides will come through as PDFs for your review, so you can take a little bit closer look at this. So I'll move forward. Now, there are two ways that you can do buprenorphine induction. It can either be in office or at home. I think that for the majority of individuals that are on this call, the in-office induction is not what they're going to be doing, just because that ends up, that means that the patient is going to be in the clinic for an extended period of time. And especially with COVID, many places are not set up to do that. So, but the key components of this is that the individual, in order for you to do the induction, has to be off of whatever opioid that they're using. So if it's a short-acting opioid, such as heroin or immediate release morphine, then about 12 hours or more since their last use, versus our longer acting, such as their extended release oxycodone, it's got to be at least 24 hours. And that really has to do with the fact that buprenorphine has a very high affinity for the mu opioid receptor. And so it will displace any opioids that are present, and that displacement of opioids is what causes the withdrawal symptoms, and the kind of rapid displacement causes precipitated withdrawal. And so people feel incredibly crummy, and they can be diaphoretic and nausea, vomiting, diarrhea. And so you really, both for, the patient's experience, and just kind of that causes a lot of stress if that happens in the clinic. You want the person to come in having some evidence of withdrawal. Of moderate to severe withdrawal. And so there are clinical scales that you can use, and I'll show those towards the end. And then when you feel that the person is in sufficient withdrawal already, so that means they have a low amount of the opioids that they've been using occupying their receptors, you'll give them the buprenorphine naloxone, the 4 mg/1 mg combination, monitor them for an hour, and then based on whether or not they have continued withdrawal symptoms, redose them versus you've achieved their maximum dose, and then you can write the prescription and then follow up with them by phone, in person, or e-health in the next few days to see how they're doing. The home induction protocol follows a similar, framework. It's just that it's unobserved. Though some places are doing this using telehealth, and as a part of this unobserved dosing, you're going to counsel the patient that you want them to be in moderate withdrawal, and that it results in you having a conversation about what does their withdrawal symptoms look like. You're going to also talk with them about what precipitated withdrawal looks like. Again, many patients already have familiarity. You can give patient instructions for them to take. Like I said, there's a clinical scale that you can use, or a scale that the patient can use, which I have on the next slide. You're going to have them start off for the 2 mg, 0.5 under their tongue, wait 3 to 10 minutes for it to dissolve, and then after 2 hours, redose themselves. And really looking for, somnolence as a stopping point. I have this listed out, and this is what's endorsed as the approach that we should be using to do induction. Many patients are not buprenorphine naive and may know what has worked for them and what has not. And so going straight to the 8 milligrams for that person as their first dose may make sense for that patient. And so really it's about some flexibility and titration. There isn't this, hard and fast that this is how it's going to work for every patient. And so these are the scales. I have the links here. So when you get the slides, you can go to those so that you can print them out and have them present and use them either in the clinic or give them to patients. And now we'll talk about what some of the next steps are. And these are very similar to what we already do when we're thinking about the management, of somebody living with HIV, somebody coming in for pre-exposure prophylaxis, is really, looking at, are they having any side effects? How are they doing in terms of consistently taking their medications? And then are we achieving the therapeutic benefit? So are they having cravings? Is there continued opioid use on top of that? And what does that mean for the patient? Some may want to decrease their use, others may want complete cessation. And then in terms of our monitoring is looking at treatment progress. And so we'll have our frequency of visits, especially early on, to make sure that the patient has been successfully inducted. And then as things kind of stabilize and they're in the maintenance phase, we'll space them out. We can do random drug screens, which we'll talk about, to make an assessment, as well as random medication counts. And then in terms of, and that's really for mitigation of diversion, to do the kind of random calling and have the person bring their medications in. Though I would caution to be careful, because if you've prescribed low dose, the patient may take more, and that may be a result not of misuse, but really of kind of subtherapeutic dosing. And then, of course, we always have overdose and relapse prevention with our naloxone. So irrespective of whether or not your patient takes medications for opioid use disorder, please make sure that you're doing prescriptions for naloxone, and then determining what counseling or psychosocial support that person may need. For the urine drug screens, I think that the most important thing for you to understand is that this is not how we determine whether or not treatment is working or not working. As I tell my students, this is a tool to help us have a conversation with the patient. And so, the example I give is that, if I go to the doctor and they ask me how much my weight is, they're not going to get the truth. So if you need an objective measure, have me go on the scale. And so and then we can have a conversation about what's the difference between what my perception is versus what's happening as a part of closing the gap. But this is not going to be, the end all be all. This just represents an opportunity for us to determine where does the patient want to be versus where may they actually be. But there are a lot of issues around the urine drug screens. They're not 100% sensitive. Depending on the chronicity of use, up until that point, they can still be positive, even though the person has stopped using. And then they're not able to detect all substances unless you have specially requested that be tested. So for instance, oxycodone is not going to be detected unless that's unless you're doing special testing for that. The same thing for fentanyl, carfentanil, and then similarly for not all benzos. So I would be careful if my patient is receiving clonazepam and it doesn't show up positive on their urine drug screen. That shouldn't be that the assumption is that they're not taking it correctly. It's that there may be assay issues. And so again, this is the idea about this being a tool. In terms of concerns about drug interactions between buprenorphine and HIV medications, we can see increases of buprenorphine related to unboosted atazanavir, ritonavir, as well as elvitegravir and cobicistat. The only ART that's contraindicated with buprenorphine is unboosted atazanavir. Otherwise, you can do your atazanavir, ritonavir, and your elvitegravir, cobicistat formulations without any issue, and just monitor the patient. If they're saying that now, because you've done medication switch, they are noticing increased sedation, that may be because their buprenorphine levels have increased. Similarly, for efavirenz and etravirine, we see that there's a decrease in buprenorphine, and so it may mean that you have to increase the amount that the patient is getting. But this is not uniform across. And then we don't know about the effects of the protease inhibitors with boosted cobicistat or a CCR5 antagonist. And that does not mean that you should not give that. It just means we don't know. And so, you know, it's about monitoring of our patients. All our other classes that are not listed here, there's no change in our buprenorphine and there's no impact on their ART. I know that I am close to our time, and so I don't want to get in the way of our Q&A. I do want to make sure that we're at least talking about safer injection practices as a part of our harm reduction. And your safer injection practices don't even have to, you don't have to go through all of these components. It can just be highlight one based on how much time you have. So you can talk about drug preparation. So as if your patient is diluting their heroin, you can talk about, you know, using bottled water, or if it's not bottled water, then it's boiled water. If it's not boiled water, they can use tap water. If they don't have tap water that's available, let's say they have to, you know, out of unfortunately, sometimes toilets, you want them to get it out of the top of the tank rather than out of the toilet bowl. So these are the things that you can talk to the patients about. Cleaning the injection site, alcohol swabs, please provide your patients with alcohol swabs, also prescribe them at the pharmacies. Make sure that you know about, you know, needle or syringe access programs and the idea of really not reusing, but if the patient does have to reuse, that they can, you can see this figure here at the bottom, excuse me, in which they first fill up the syringe with clean water, then they can shake and then eject out that water. Then they would do a similar thing with bleach, with a solution of bleach, draw it up, shake, dispense, and then finish it off with another draw out of clean water, and then shake and dispense. And then about injection site care is our similar wound care and making your practice available so that they can come in to receive services, to receive treatment if they do have something that looks concerning. I talked about increased rates of overdose and overdose-related mortality, as well as all-cause mortality without treatment discontinuation. There's a very nice study here, and I realize I have the slide duplicated. This is the better slide showing that looking at increased healthcare utilizations after discontinuation. So please encourage your patients to remain on treatment and assess what may be barriers to remaining on treatment long-term. And then lastly, please get waivered, because unfortunately, as it currently stands, we cannot prescribe these medications. We cannot prescribe buprenorphine to more than 30 patients without getting a waiver. There continues to be tremendous advocacy to the X waiver, if you will. But until then, please get your Data 2000 waiver. Now, like I said, there's been recent order that allows you to new practice guidelines that allows you to be able to register without doing this training. So please go to the SAMHSA website so that you can do the notification of intent to prescribe, and then check off here that you wish to apply for the 30 patient level with the exemption. So that's no training. And on there it has that within, I can't remember now, unfortunately, 60 days, they'll notify you. If they haven't notified you, then you're allowed to prescribe. And there are a lot of resources. ASAM has resources, PCSS has lovely resources, webinars, and all of those things. So please, and then my apologies for not including the Opioid Response Network, is again, having lots of resources available. And so with that, I'm ready for the questions.
I'll unmute myself to thank you. Thank you very much for that presentation. It was extremely informative. We do have some questions in the Q&A. Would you like me to read them to you, or are you able to access the pod?
I am able to access. I'm going to get out of share screen, and then here I'm in the Q&A. Let's see. So from our first one is, in some states, we often see PCPs referring PrEP to HIV clinics, which are few and far between. What would you recommend is needed to allow PCPs to be primary providers for these medications? What other gaps do you see with PCPs regarding HIV treatment? So I think that one of, we have, fortunately, HIV treatment has become more and more simplified. And so primary care providers really can take this on, both HIV prevention as well as thinking about HIV treatment. And so I think that looking to resources for Project ECHO, which ends up being a collaborative learning in which you have an expert in whatever the area is, it can be substance use, hepatitis C, HIV, or HIV prevention, that leads a group of providers that's not necessarily their specialty, to gain skills in that area. And then it ends up being over kind of a longitudinal, monthly course or bi-weekly course over several months to build up those skills. It was developed for the purposes of really trying to increase the capacity of our primary care population. So I think utilization of those types of resources is helpful, in addition to all of the different things that the AATC provides, so that we can increase our provider capacity. And then let's see, Lisa asks, are Suboxone or naloxone patients included in a reporting category for buprenorphine? Yes. And then is Suboxone more or less popular than other buprenorphine containing MAT? So yes, so we've kind of got two formulations, buprenorphine monotherapy or combination buprenorphine naloxone. The naloxone on that formulation is supposed to be a part of a diversion to prevent diversion or misuse, because in theory, when you take naloxone sublingually, you have no effect. But if you were to dissolve and inject it, you would experience the effect, and that would give you withdrawal symptoms. And so that is why that the combination buprenorphine naloxone is the preferred option. There used to be the idea that buprenorphine monotherapy should be first-line therapy in pregnancy. There's more and more literature showing that probably the combination product is fine, that there's not increased negative outcomes, pregnancy outcomes, to be exposed to naloxone, and especially for women who become pregnant that are stable on the combination product, really perhaps not changing their treatment formulation just because of pregnancy. And let's see, when was MAT recognized as the gold standard? Are patients expected to discontinue MAT eventually? And so there, this literature has been rising over the course of several decades to really show the superiority of MAT or MOUD. And the literature, we don't know how long people should stay on it in order to allow reversal of some of the neurocircuitry changes that have happened. And so at this time, it's having patients stay on it for as long as possible. Some places may say at least 12 months, but really as long as possible. And then thank you, Lisa, for that shout out and updating our terminology. Within your treatments, do you recommend the use of social therapy? Yes, I think that any of these groups, because this is what I also tell my patients, many things have happened to them, either before they started using or after or during their process of using. And these medications can't address that. They cannot address the potential social isolation, the trauma, the underlying trauma or mental health needs that it cannot be addressed by this pharmacotherapy. And so counseling and other psychosocial supports can be very helpful. Sometimes it's about finding what support community is a good fit for them, because some of the communities, unfortunately, are abstinence only communities, which includes saying that being on MOUD is not acceptable. How do I use UDS in my practice? Seems they're being considered more stigmatizing, traumatizing, and decrease patient and provider trust. Should we stop getting them? I think that it depends on what things look like for your practice about how do you want to use it. So for instance, if I know my patient has, they were lost to care and they're coming back and we're talking about it, I know that they ran out of their buprenorphine-based prescription their buprenorphine naloxone prescription. And so in all likelihood, there's been return to use. They tell me that there's been return to use. I don't necessarily know that checking a urine drug screen at that time is going to do anything in terms of giving me information I don't have. Now, I may check that but patients also, as they're going along in their process, like seeing their urine drug screens no longer be positive for opiates and only be positive for buprenorphine. So there's that, kind of like with checking our viral loads, right? We're like, oh, you don't have to check your viral load anymore. Your CD4 count's over 500 and you've been undetectable consistently. Like or I shouldn't say anymore, but that frequently. But the patient may still want to, stay on that every 3-4 month kind of routine because that's comforting to them. So there's somewhere in between as my approach. And it's really to be able to have open conversations. I will also sometimes do metabolite testing for Norbup as well, so that we can look at that at those levels. So it really is only as a tool. And Benjamin also asked about any update on Sublocade Quick Start. So far, we don't have. There's a lot of interest of just doing extended release buprenorphine, that subcutaneous injection, just go directly to injecting rather than the person needing to be on oral on sublingual buprenorphine beforehand, but there's nothing that's officially come out to say that move can be done. Can I discuss harm reduction with microdosing? Yeah, so buprenorphine, so this is again something that hasn't been codified as a strategy, but there's a lot of interest and a lot of literature that's coming out about trying to think about how do we make that first step from opioid use to getting on buprenorphine because of this issue of it having a strong affinity for the mu opioid receptor. So how do we prevent precipitated withdrawal? Microdosing may, but has not necessarily been definitively codified, be the strategy to prevent precipitated withdrawal. The basic idea is that strategy, the induction strategy I talk about, if you extended it over several days, so start the person on a very low dose, they take that day 1, take a slightly higher day 2, slightly higher day 3, etc., but they may continue to use whatever opioid on top of that, they will start to feel, that will allow that transition to kind of maximum dose of buprenorphine that is needed, that will stop them from experiencing any of the effects of the opioids that they're receiving. So I think that there's a lot of desire to really see that robustly demonstrated and kind of further refined, but it is a strategy and something that, depending on situations with patients, I will employ, especially if even being in moderate withdrawal is too high of a barrier for that patient to be able to overcome. And then let's see, is Suboxone, so brand name Suboxone, the most commonly prescribed buprenorphine containing medication? I honestly don't know. My perception is that it is out of the brand name, but though there are a lot of generic formulations. And then do some patients stay on MOUD for life? Yes, and I think we have a robust literature of that in terms of patients that are on methadone, that they, that they have that a part of their regimen, just in the same way as HIV medications, hypertension medications, et cetera. And so that's really what we're trying to think about and change the discourse and the perception for people to be more open to conceptualizing this pharmacotherapy in that way. And then lastly, Carlos, what do you suggest in the behavioral and psychosocial aspects of people who use opioids and remain on the streets? And then I'm not sure if Carlos is still here, because I just want clarification in terms of remain on the streets, in terms of was that are experiencing unstable housing and homelessness, or just continued drug use? Oh, maybe Carlos has left. For the, I think any behavioral supports, therapeutic communities, recovery support communities are important and necessary, or can have a value. The literature does not show that mandating and potentially withdrawing the receipt of MOUD if someone does not want to engage in those additional supports has any therapeutic benefit or decreases morbidity or mortality, by restricting access to MOUD. But I think that at least for me, for many of the patients that I see that have, in addition to their substance use, also have HIV, have trauma, may also have severe mental illness as well, having that really kind of a full package of care has helped them have better outcomes. And then definitely case management, because many of the times, either because people may also have criminal justice histories as well, and that may affect their ability to secure housing. Like we really have to work as a team to address many of the systemic barriers that exist as a part of our criminalization of drug use and our society having stigmatized drug use. So that comprehensive care definitely is necessary, especially when individuals are experiencing unstable housing or homelessness. And then for those that continue to use opioids, it really is a discussion about what is their goals. And I just think I just had clinic before doing the webinar, and some of the patients, as I talk about, well, what's happening, what exactly is going on, the psychological impact of COVID has been so tremendous, not only in terms of the isolation, but loss, people being very concerned about what that means for them in terms of their potential to get sick. I've had, patients that family members are sick, they want to help them, but they're also afraid that they themselves will get COVID, and then all of that, very complex feelings that come into this, this place of helplessness. And, medications, can't address that. But it's about, what is the person's willingness, to engage in those types of treatment paradigms, because since, unfortunately, mental health care has its own set of stigmas, barriers, issues about obtaining access. But I think, there isn't MOUD is important. It is the foundation, but it is not the silver bullet, but an important and necessary component for us to really address opioid use disorder. Oh.
Here I go again. Thank you very much. It's such an informative presentation, but also to be able to get your insights into practice and care, and your passion has been amazing. It's been a great session, and majority of folks have hung with us throughout this question and answer period as well. So I know they all appreciated your insights as well. So thanks you everybody for attending. If you're looking for the continuing education credits, please make sure you fill out the evaluation and you'll be hearing from us. Any other closing words, Liz, or did I cover all of that?
That was great. Thank you, Daria.
Okay. All right, all have a fabulous weekend.
Thank you. Goodbye.